Good afternoon. Okay, I know we're here at the end of the day. A lot has been learned, a lot of conversation. I know we're maybe a little bit more tired at this point, but I think we're all looking forward to our panel on changing the culture as it relates to mental illness and behavior, or mental health rather, and behavioral health. So good afternoon, I'm Dr. Aletha Maybank. I'm Deputy Commissioner, the New York City Department of Health, as well as Founding Director for the Center for Health Equity, which is a newer initiative in the city of New York to really elevate our conversations around health equity and health disparities.
She's supposed to introduce the panel.
Oh, somebody else is here. Okay. Oh, I didn't realize. Okay.
That's okay.
Thank you.
We do fast adapting here. My name is Lori Golden. I'm Ernst & Young's Ability Strategy Leader, and that means I focus on how we can build an environment and a culture where people of all physical and cognitive and mental health abilities can do their best work. We're one of the world's leading assurance, tax, transaction and advisory firms, and have 103,000 people in over 160 countries around the world. But let me share with you why emotional well-being is so critical to our business and to the culture of caring you heard my colleague Sandra Turner talk about on the employer panel this morning. We're consultants and we're professional service providers. We work in teams. Our only assets are our knowledge and our ability to solve problems. So if one member of a team is struggling, the entire team is impacted. To do our best, all of us need to be our best. But what we do is not just about inside E&Y, and that's why we're one of the sponsors of this conference. We all have families, friends, neighbors. We want to build a better working world and live in healthy communities where everyone can participate and contribute. That's why this conference is so important to us and why I'm excited to reintroduce this next panel, because this next panel is about how to change the culture in our cities, break down stigma and other barriers so that people can get the mental health support that they need. It's my pleasure to turn it back to Dr. Maybank.
Thank you very much. Thank you. So today we're going to be talking about how our cities across the country really creating awareness and knowledge to markedly change the culture of illness. And I think the culture or changing the culture means different things to different people. And so for us, as Thrive NYC and our guiding principles, changing the culture means make mental health everybody's business. But it also can mean how are we shifting and broadening our conversation from a perspective of criminal justice to public health, and what are our approaches and strategies to doing that? It also means how do we expand the narrative around the root causes of what really creates mental health. And so not only just talking about what we say in public health, the social determinants, but how we talk about housing, how we talk about income, but how are we also talking about forms of oppression as it relates to racism and all the other isms and its impact on mental health. And it also speaks to how do we really tell the stories of those who are experiencing mental health or are part of the criminal justice system and have been victims of that. How are we elevating their stories to really work on changing the culture of health? Because all that really works towards that end. And so today on our panel, we have 4 cities that are represented, and they're going to speak to how are we teaching people to help friends and families and coworkers break down stigma of mental health. We're going to talk about how are we doing intersectoral work with other city agencies as well as other community-based organizations. How are we providing a more professional and humane response to treat individuals in serious mental health crisis? And how are we helping to divert individuals with serious mental illness or co-occurring substance abuse disorders into community-based treatment and support services? So starting on my far right, or my immediate left, I should say, right here, we have Dr. Micaela Mercado, who is Assistant Commissioner in the New York City Department of Health under the Bureau or Division of Mental Hygiene. We have Dr. Judith Martin, who is Deputy Medical Director in San Francisco, coming from California. We have Chief Martha Montalvo, who is Police Chief of Houston, in Houston, Texas. Captain Wendy Bainbridge, who is from the Mental Health Division at Houston, Texas. Alejandro Aristizabal.
Almost.
Almost. We practiced this ahead of time too, and I still messed it up. But who is Felony Diversion Supervisor in Miami-Dade, Florida, as well as Daniel Jr., who is the Interim Director for Corrections and Rehabilitation Department, Miami-Dade, Florida. So I am going to allow each person to provide a quick overview of the work that they do, keeping in mind the question about what does changing the culture mean to you, and how are you applying that to your work? So first, can we start with Dr. Mercado?
Great, good afternoon. Thank you for this opportunity to present our work. I don't know if everyone's received their folder, but in this folder, you'll see there's an executive summary of our Thrive NYC roadmap to mental health. And this morning, we've also heard about the data that's really informed our work. And so kind of taking that as a foundation for how we want to think about changing the culture, I also wanted to pose some questions to our audience to see, if these data points really ring true to you, not only personally, but professionally, but also as in terms of the work that you're doing. So by show of hands, how many of you have been personally, professionally, in your work been impacted by mental health? And as we know from this morning, the First Lady clearly indicated that this impacts us all. Yet we do realize that one of the primary barriers to trying to address mental health is stigma. And fundamentally, that's one of the primary, discussion points, I think, when we think about changing the culture of health that I wanted to really take some time to really help to really think through what are the strategies, but also what are the vision and how are we moving forward and really tackling these things when everyone feels this close to their heart, but also maybe more importantly, how do we move policy in that direction? And so what we did, or at least what was presented when I started my job, was we need to reach 250,000 New Yorkers and train 700 instructors in mental health first aid. And I said, well, that's an easy task, right? 8 million people, I can find 250,000 people out there. Sure, but of course, this involves a lot of infrastructure development. The messaging has to be very clear because it is a significant cultural shift in trying to, in your face, kind of bring up these issues that are very difficult and certainly not an easy topic to bring to our communities and even in our own professional workplace. And so what we did was we've selected an evidence-based practice. How many of you know of mental health first aid or have heard of the practice? Great. So I will refer you to the National Council for Behavioral Health's website. They provide a lot of information around the practice, an evidence-based practice that was developed in Australia and brought here and adopted by the National Council. So in essence, what the strategies, or rather the framework that we're tackling, is how do you bring this to our communities? And our initial phase of work is to really start developing this culture within our own organizations. We are currently doing intentional outreach to city agencies across the city, Department of Education, Department NYPD, NYCHA, all of our city agencies that are really not only spearheading some of this in their own way, but also are very much interested in receiving technical assistance from us. So we framed it in that way. Where we can provide some resources to each city agency to be able to change their culture, how they perceive mental health, and how it impacts the work that they're doing. Our second phase of work is really reaching out to providers and the community. What's been interesting is that you have about 15 city agencies that are doing this work. and each one has its own variation of how they want to implement mental health first aid. And that is part of our technical assistance package, if you will, to really try to understand and learn from them, to really be able then for us to disseminate that information and really develop the partnerships and collaboration that will be needed to reach 250,000 New Yorkers. And our third phase is sustainability. How do you train 700 instructors in mental health first aid and ensure that that model sustains itself and maintains its momentum, especially given all of the investment that is being done in the forefront of the work? And so, going back to Dr. Maybank's question, how do we start talking about sustainability with this very large model? So a few things that we're considering in our technical assistance work is, as city agencies are lifting this off the ground, and as we're learning from them and disseminating the information that they're collecting in terms of implementation, their ability to engage the community in this work, we're also looking at organizational policies that could potentially really strategically embed and integrate this work that's beyond the 5 years of funding that we've received. And so some examples would be for every new hire orientation, to require your new hires to be trained in mental health first aid, or to at least provide an opportunity for them to engage in that training process and to sign up, even if it's at their own voluntary time, but also maybe as an organization to provide that. Another Thrive initiative called Connections to Care. We've talked about a way to have our community-based organizations think about new hire job postings. So we're integrating and have embedded ways to include mental health first aid or mental health capacity skill development in the job posting. So the requirement of the position is that if you do not have this skill, or if it's an area that needs to be further reinforced through your work, that you know that the professional development opportunities will be there for you. Because we are reaching so many individuals through this initiative, it's likely that through our Connections to Care initiative that we are able to kind of set the momentum for the hiring process to engage into individuals that when they're working in employment services and children's services, that these individuals are attuned to these skills, or at least attuned to the idea that this agency, my new employer, is very much interested in bringing mental health to individuals that I'll be working with. So again, another way of thinking about cultural change. So I will stop there and I'll let my colleagues continue.
Thank you very much. Thank you. So I want to make sure, I just want a quick point, is that we have 6 people on the panel, and I want to make sure that we do get to a conversation and a discussion. So if we could, keep the comments to no longer than 4 to 5 minutes, that would be fantastic. Thank you. That's okay.
My name is Judy Martin, and I'm a physician. My specialty is addiction medicine. I'm the medical director for substance use services in the city and county of San Francisco. And before that, for 26 years, I worked in methadone clinics and in primary care. And also with buprenorphine, and I've trained a lot of physicians around the country in how to use buprenorphine. I think there have been several areas where the culture has changed in my lifetime regarding substance use. The main one is the medical model. Another one is the stages of change. We don't say, wait till you hit bottom and come back now. We call that pre-contemplation, right? And so we know ways to approach it. Another big area is in San Francisco in particular that affects how we work in San Francisco, is that we try to make drug use and alcohol use as safe as it can be for people. And so, in other words, we care about wellness in our drug and substance using population. And so people who use needles, for example, have syringe access, and people who use heroin and other opiates have community access to naloxone reversal. And Our population in San Francisco is 850,000, so it's not nearly as large as you here in New York. In 2015, we had 600 bystander naloxone reversals of overdoses. That means that our people who use drugs in San Francisco are very sophisticated and are taking care of each other and watching out for each other. And it shows that you don't have to wait till you're in treatment to get better. You can do things that are self-sufficient and in your in favor of your own well-being. And I think that's something that when I first started in treatment, when I was a treatment provider, was not particularly part of the culture, and it has become. Our Board of Supervisors actually has a harm reduction policy, and it's been there for 10 years, maybe 15 now. So even our treatment providers are required to have a harm reduction policy written in their treatment programs and an on-site overdose reversal plan on site, and to either provide or post access to naloxone. That's in their contracts. And in terms of alcohol, one of the things we have that always people are very interested in, and I think is a cultural change, is when people are very inebriated and picked up by police or emergency from a 911 call, instead of clogging up the emergency rooms simply from alcohol intoxication, they're taken to our sobering center, which is staffed by nurses who can evaluate the person and do triage. If they need to go, of course, to the emergency room, they go. But otherwise, they have round-the-clock RNs watching them, and they're given a cot and a shower and laundry and a warm meal, and offer treatment, of course. As I said earlier, not everyone wants, in fact, the majority of drug users in our city don't want treatment. That's true all over the country. Another area of culture change, I think, that's happened is that there's a consciousness, as you pointed out, of the huge racial disparities that exist in the substance use field. We are way overrepresented in terms of comparing the regular population of San Francisco versus who's enrolled in substance use in the safety net, with Latinos and Black and African American citizens. And when we even, aside from that, when we look at how Black and African American people do in our system, we see racial disparities. One of the things we're working on is the disproportionate death rates among Black and African American men from alcohol. And we've looked at data regarding this in various ways, and we noticed that the use of alcohol treatment medications is percentage-wise much lower in that population. And we did several humble inquiry sessions with our clients and with our treatment providers who are Black men, and we found that some of it is mistrust of us because we're the medical system, kind of we are the man, and very well-earned mistrust of the medical system, of course, when you consider things like Tuskegee and so on. And also, perhaps another area is fear of being labeled and locked up, so fear of disclosure of even having an alcohol problem in the first place. And so building trust with our communities of color is one of our priorities as well, which we didn't hold that in the forefront so much as we do lately, so.
Good afternoon. Martha Montalvo, and let me just correct, I'm the interim police chief. Thank you for the promotion, though. Maybe it'll come true. I'm with the Houston Police Department, and up until about 2007, we handled calls in regards to those who were mentally ill, just like every other police department, either through incarceration or we did an emergency detention order and put them in a facility. The problem with the emergency detention order was it normally took us about 7 to 8 hours. So guess which one the officer normally would take? Incarceration. Up until 2007, there was defining moments for us. It was 2 incidents that happened that year within 2 months of each other where officers dealt with individuals that were mentally ill, suffered from schizophrenia, and they were extremely violent. And the officers handled it with deadly force. That, along with public pressure, forced us to look at how we were responding to mental illness. There was a lot of research done. We had a great relationship with our partners in the mental health professionals. And with their help, one of the first things we did was training. We wanted to train our officers on how to deal with the mentally ill. So the first thing that happened that year was we developed a training program for all police officers. And fast forward to today, all police academy classes have training in crisis intervention training. All officers prior to that time period were mandated to receive 16 hours of crisis intervention training. And then we receive 8 hours on a yearly basis, which is a refresher course. In addition to that, we've also trained our jailers as well as our call takers and dispatchers. In 2013, because of the success of the training, we decided that we needed to grow that concept. And in 2013, we actually, and I think we were probably the first ones in the country to do this, we developed a unit that was dedicated to mental health, a whole division that their whole concentration was going to be mental health. And out of that unit, what we had is 12 crisis intervention response team, CERT teams. This is a team of one officer with one clinician that responds to crisis calls. We have a CCSI team, which is the Chronic Consumer Stabilization Initiative, which is one officer that works with 6 caseworkers. And what they do is they work the chronic callers, the individuals that are repeat customers in terms of needing services. And what they try to do with them is provide them with the outreach and the services that they need so that we can solve the issues more long-term. We have a HOT team, a homeless outreach team, which does street outreach. In 2015, they provided 300 individuals with housing and 4,500 individuals with various different types of services. This need, especially in our city, and I'm sure in San Francisco, is just it's becoming a very huge problem for us, to where I've had to add additional officers to this support. And what we have there is 1 sergeant, 6 officers, and 4 case managers that work with us. We have a boarding house detail now. As you can see, this has started growing in terms of services that were coming to the police department that we had to be addressing because, as we all know, a lot of these type of, there's a disinvestment, I guess is what you call it, in these type of services. And the ones that end up having to respond to this is the police. And I tell a story to individuals that I speak to of an event that I went to, and there was a lady that was speaking to me, and she was telling me that she couldn't find services for her daughter. She went to various hospitals that didn't have the facility for her, or they didn't treat her specific type of problem, or they didn't accept her health care that she had available to her. So their response to her was to call the police to provide her with help, which that's not how it's supposed to work. The last thing is the boarding house detail. This is housing of last resort for the mentally ill, the elderly, the disabled, and we have 2 officers assigned to that, again, because the need was there. There were numerous complaints that we were receiving about the treatment of these individuals, so we felt a necessity to make sure that we were ensuring that these individuals were living in a safe and healthy environment. But And we just started a 9/11 diversion program where we are actually putting clinicians with 9/11 call takers so that the call takers are trained in how to recognize these type of calls, and when they receive them, they divert them to a clinician to be better able to service these individuals. So I guess the main thing I want to say here is we started this off, we wanted the training, and it has since grown, but we didn't grow by ourselves. We ensured that we brought in the experts to help us in making sure that we provided the necessary services. And I think that that's what this conference is about, that there has to be partnerships, there has to be collaborations, and there has to be communications among the different groups that deal with these type of clientele. Thank you.
Hi, my name is Captain Wendy Bainbridge. I work in the Houston Police Department's Mental Health Division. And before we started all these programs that Chief Montalvo just spoke about, we felt the need to, because the most successful programs are fact-based. And so we had to gauge and quantify the demands of our public placed on the Houston Police Department and our 911 system that are really mental health care related. For instance, last year we had about 36,000 calls to our officers that were just mental health related. There was less than 0.1% of these calls that ended in an arrest, but 7,300 of them were emergency detention orders. And that's when, of course, someone's in endangerment to themselves or others. 33% of those emergency detention orders is where there was a criminal nexus involved. Somebody in crisis committed a crime. But because of our training that the chief just spoke about, our officers now know what a crisis looks like. And because of our collaboration with our mental health authority, we now have a place to take them. And that 8-hour process has become a 15-minute process because of that collaboration. Only 44 people were booked in our Harris County Jail that were in crisis and had committed a crime. About 2,500 were diverted away where we could have taken them to jail. Again, because of policy and training, we now have a place to take them. Because of our healthy collaboration, we also can work with our mental health authority and getting these folks into their system instead of ours. Because if we've heard all day today, gone, are the days that we can work in silos. We are not efficient, we are not effective, we're not using taxpayer money wisely that way. And we can't be generalists. We need to be specialists working together, and it does work. Our 911 diversion program is another example, and this is in its infancy, and we're piloting it now, and we received outside funding because we were able to quantify the demands on our officers for this purpose. We have crisis hotline counselors from our mental health authority now taking calls that we can safely divert away from our officers having to run, and now they have a licensed mental health professional working with the public that can actually call people back to see how they're doing and to explain things that are going on. Out of the 38,000 calls that we had, about 11,000 of them were just cleared information. It wasn't a crisis, it wasn't a crime, it wasn't even a report type incident. And so now we have specialists that can actually handle those calls instead of the police going out there and not really helping that family whatsoever. Thank you.
Good afternoon. Anybody want to give it a shot at pronouncing my last name? So I'm Alejandro Aristizabal, and I work for the criminal courts in Miami-Dade. I think we're the third largest court system, of course, New York and LA being top two. My background is in community mental health. I have about 15 years experience working with serious mental illnesses and co-occurring disorders. And I want to talk about personally how I'm trying to change the culture every day. I work closely with our judges, with our judicial administration in Miami-Dade, and almost daily I am in a room with a prosecutor, with a defense attorney, and with a judge. And I'm not a lawyer, which automatically means my credibility goes up way beyond there. But that's how I try to change the culture at their level. They tell me they receive no education about mental health and substance abuse in law school. So I could bring to them the reality of what's going on the ground, on the front lines, in our communities. That's one of the ways I'm trying to change the culture. The second I wrote down is whenever we have efforts at funding programs, we go to our Board of County Commissioners, and I don't take them statistics or charts or pie graphs. I take them people. I take them individuals that have been through the program, family members that could sit there and tug at their hearts and show them that it's real. And the feedback we get is that it works, that it really touches you. When it's personalized, we realize that it's a lot more real than the statistics or the charts. And then lastly, I'll finish that I work very closely with our community treatment providers. Sometimes as mental health professionals, we are some of the biggest perpetuators or proponents of stigma. We don't realize it, but we may very well take this home to our families and talk about all the trauma that we experience daily or the human tragedy that we see, and it automatically has our family and friends thinking that we may need mental health services. But my efforts with the community treatment providers are usually about realizing and trying to get the culture of, is this a client or a patient that is treatment resistant, or is this a client resistant treatment provider? And trying to get the providers to realize, make this welcoming, make this a warm handoff. Don't just give someone an appointment and have them hope that they show up, really holding the hand of the individuals. My expertise is basically in community reentry from either hospital settings or jail settings, basically community reentry after institutionalization. And that's what I do every day. I have a team of excellent professionals that we work with in Miami, where we are basically making sure that our community is a little bit safer, because now you have a coordinated release from jail with medications, with shoes, with food, with an appointment. And that's what I do.
Good afternoon. So I work closely with Alejandro in Miami-Dade. So all day they've been referring to us as the Crockett and Tubbs of mental health. So feel free if you agree with that sentiment. I'm Dan Jr., the interim director of Miami-Dade Corrections Department. For those of you who don't know, the jail system in Miami-Dade is the 8th largest within the United States. There's a national trend that most of you may be aware of, that population has since declined significantly over the years. About 10 years ago, we were average over about 7,500 individuals in our jails. Just checking the head count this morning, we're hovering at a little over 4,000. And a lot of that has to do with a number of different factors, but I can also credit the jail diversion program through Alejandro's program with diverting a lot of those individuals that don't have to come into the jail to receive the proper treatment. If you would have told me 10 years ago I'd be sitting here on a panel to discuss best practices with regards to treatment of mentally ill within the jail, I probably wouldn't have believed you. And what brings us here today is not because we've done it so well over the last 10 years, but probably because we've done it so poorly about 10 years ago. And I'm just being honest. About 10 years ago, we house our acute and subacute mentally ill individuals in one of our oldest facilities, built in the 1950s. And those of you who've been around the jail system long enough, you know these jails weren't built with the concept of mental health treatment, care for the mentally ill within the walls. So we gained a lot of negative publicity with regards to that, a lot of local media stories. It was actually deemed as the forgotten floor in our jail system, where we kept most of our suicide and acute population. We also had a visit about 10 years ago of the author Pete Early, the author of the best-selling book, Crazy. He visited with us 10 years ago, and he referenced some of the challenges that we were experiencing in his book. In 2008, the Department of Justice came in, and that prompted an investigation from the Department of Justice, and they issued a findings letter in 2011. However, we had already begun work to address this issue because we recognized that we can do a better job in this area. coming from someone whose family member personally suffers from mental illness, you kind of put a personal connection with that. What if my family member had to come through the system and this is how they're being treated? So since that time, we have since looked at our intake process. We've looked at our housing for the mentally ill and so forth. And since that time, we have since identified funding. We use about $2.5 million of our operating budget to completely retrofit our centralized intake unit that was open in 2013. And also in 2014, we retrofitted about 7 housing units to transition our acute, subacute to a new mental health treatment center. Back in 2005, we had a population of about 400 on the mental health caseload with 1 psychiatrist to service that entire population. Since that time, we've onboarded 12 new psychiatrists and 100 plus clinicians to service about 700 acute and subacute. We also introduced a number of different programs. We have music therapy. We're currently doing yoga, also art therapy, anger management. Back in 2005, the individuals were not getting as much out of the cell time as they were, as they needed, but we have since made a lot of advances in that area. So again, I'm happy to be here. There's a lot that we've done because we bumped our heads along the way, but we're here to share those stories with what brought us to this point in Miami-Dade, and I'm open to any questions with regards to that. Thank you.
Thank you. Thanks to the panel for sharing your dynamic work. Very much appreciated. I want to build on talking about, everyone's mentioned how you have had to work and how you're working with very intentionally other either city agencies or other divisions within your agencies, other community-based organizations. And we all, I think, are pretty clear that that's important to shifting and changing the culture. However, it's not always easy to do that because oftentimes we are speaking very different languages. I very much understand it from the public health end. When we sit with another city agency, sometimes you're just not on the same page. And so there's a lot of work potentially that we have to do in order to get on the same page in order to move forward. And so I wanted you to speak to what is some of that work that you've done in terms of capacity building of your certain organizations so that you are able to speak with other agencies and other organizations, and what are some of the challenges and how have you overcome that? So anybody's more than welcome to answer and take that question, and as many as want to. Mm-hmm.
Well, at HPD, when we first started, it was unheard of to work with mental health professionals. Many of our officers thought, this is not police work, what are you doing? Mm-hmm. But the issue is the public is still calling us. And what we are now a learning site because we've come so far. We have 40 hours of training in our cadet curriculum. 60% of our officers now have had the 40 hours training, all others 16. So we're doing a better job with it to the degree that the DOJ has named us a learning site along with 5 other law enforcement agencies to teach other law enforcement agencies across the country and train them in CIT, crisis intervention training. And I tell all of these agencies there are 3 things you need to be successful. 1 is absolutely training. That must be the foundation of all your innovative strategies. And 2, you must have a good data-driven system to be able to gauge your results. For instance, our Chronic Consumer Stabilization Initiative is that proactive initiative whereby we have 1 officer working with 6 case managers out of our mental health authority. They proactively engage the folks that are using the 911 system the most for mental health care. Well, now, because they're getting that intense case management, there's an 80% reduction in the number of times that they call HPD. That officer more than pays for his salary because of that. There's also a 75% reduction in the number of times they go into crisis mode. And so there's efficiencies gained on our mental health authority side because they have more bed space opened up for others, things like that. And the third thing that I tell them that they need is an absolute good, healthy relationship with their mental health authority. And sadly, what most agencies tell us is that the mental health authority will not work with them. They will not return their calls. And we are spinning their wheels because of that, because we can train, and we are. Law enforcement is really training CIT across the nation. But you kind of spin your wheels if you can't do that proactive engagement. You're responding safer, more humanely. But unless the local mental health authority knows who your habitual users of the 911 system is, they really can't help them get out of using the 911 system. And so I think that that's very important. Like I said, the DOJ will go across and they'll ask police chiefs across the nation, what are you doing about your mental health population? And so likewise, quite frankly, I think the HHS at the federal level needs to go to the mental health authorities across the nation and say, are you working with local law enforcement for mental health reasons? I think that would go far because, again, we need to work together on this.
I think it has to do probably with staff, personnel and money, just like the police departments.
Right.
I think, so there are several sort of changes in climate that happen in a person's life when they move around in the system. And sometimes that's called transitions of care, but sometimes it's not into care. So we've done several things that I think are very useful. One is provide addiction treatment medications in as many different healthcare settings as we can, regardless of discipline. So we have methadone satellites in primary care, and every FQHC has at least 2 buprenorphine prescribers in order to support primary care in their workflow because it doesn't lend itself to daily visits, which sometimes is needed in induction.
So I think the best thing at this time, I'm going to open it up for questions. If there are not any questions, I have a question. But I will open it up at this time for questions. And if there's anything else also that the panel wants to say, that they feel they didn't get the chance to say, please feel free to also say it. Okay? So, any questions? Yes, and you'll have to stand and speak up because there is not a mic.
Irene Mori from Fordham County Human Services. My question is to Miami-Dade. Did I hear you say that you diverted funds from the jail system to create residential housing?
Yes, in actuality, the Miami-Dade County Board of Commission committed approximately $40 million in general obligation bond money to retrofit an existing county facility for the purposes of a new mental health diversion facility. 12 million of what came out of my budget, but that's neither here nor there. But it just shows our commitment and our partnership with the diversion program and our commitment to addressing this as a holistic approach to treatment in Miami-Dade County. So, yes. To answer your question, I mean, yes.
Thank you. Any other questions? Yes.
Hi, good afternoon. My name is Dr. Nicole Adams. I'm the Deputy Commissioner of Health Affairs for the New York City Department of Corrections. And in our jails, my officers are turning into counselors. I feel like our facility has kind of transformed into a treatment center. So much so that we have huddles, treatment team meetings at the beginning of every tour where our mental health clinicians are talking to our officers because we've kind of developed this philosophy of you can't enforce a rule without having a relationship and recognizing that people are sent to jail as punishment, not for punishment. Mm-hmm. So that's really changing the culture of what we used to do at Rikers Island. And all of our correction officers are not on board. Some of the pushback is we don't have the proper training, even though we do the things in the academy. Sometimes they feel like they're responding to things and they don't have the skills to adequately de-escalate things. And now that we've kind of are moving away from punitive segregation, we don't use of force anymore, a lot of our officers don't feel supported in being able to do their job in a way that's effective. So my question to the panel is, how do you, I heard you earlier speak a little about training and how that's fundamental, but how do you help, as we're talking about changing that correction officer's culture, how do you support that change happening and helping it be sustainable?
Well, one of the things we did is you have to touch everything. Even in our awards system at the Houston Police Department, we now have a CIT Officer of the Year award. We're constantly looking at ways that we can ensure that, look, this issue isn't going away. and we need to be there for our public. And we're doing everything that we can proactively with our mental health authority to take over, but we're also acknowledging these type of calls and the performance that these officers do on these type of calls because they're extremely stressful. And that is one way that it's slowly, it takes time, but slowly you can bridge that gap and go into an understanding that this is part of police work. We're trying to streamline it and ensure the mental health authority is doing what they're doing. And I heard you say that you have the mental health authority in your jail. That's outstanding. We do too. We're very fortunate for that. And one of the things that we're doing also is we're showing our Harris County Sheriff's Office that we acknowledge that there is a difference, and we just spoke about this, and this is one thing that we've learned from Miami-Dade. We flew down there and looked at their jail diversion program. And if you just look and you try to look at the recidivism rates and you're just focusing on one thing, and that is mental health, you're not going to touch it. Because we already divert those who have a mental illness away when they're in crisis. They really don't go to jail because they don't have the culpable mental state to commit that crime. So what you're getting at our jails, at least 52% of our Harris County prisoners come from Houston Police Department. They're getting not people who are there because they just so happen to commit a crime while in crisis mode. They're getting people there that are criminals that just so happen to have a diagnosis. And so we're doing everything that we can for our jailers to process and know what they're dealing with too. Communication's free. I know that it's very expensive. The payroll is very expensive, but if we communicate to them and tell them what we're doing for them and acknowledging their efforts on those scenes, then that all goes to it, and it does take time.
You could also, you got to show them why this is good for them also. Right. For instance, the emergency detention order used to take us 6 to 7 hours. Now it takes us 15 minutes. We also have a sobering center. That puts them back out on the streets a lot quicker. We got officers out there that can deal with the hardcore mentally ill type of calls for services. So it's a benefit to them and helps them go back out on the streets and handle other type of calls. And I'm sure if you look deep enough, you can find where the benefits are for your organization.
Thank you, Captain, for refreshing my memory. I think I forgot to mention a lot of ways we're changing the culture, and one is that it's true. We used to throw so many mental health services. You have the day treatment, the therapy, the psychiatry, the programming, the AA meetings, so much, but then we learned that you're getting the same results as if you did nothing about that. And what we talk about is now risk and responsivity. We're looking at evidence-based practices that show what is your risk level of reoffense. Not everyone needs that high level of care of residential treatment or of 6 days a week going to a program. And that's been a big wave of change in culture that we've experienced in order to educate our judiciary. And we have complaints, you have complaints by your officers in the jail saying we're not social workers. The public defender's office and the lawyers are constantly telling me I did not go to law school to be a social worker. And what we've been able to implement now is our judges now have risk and need level. We're not giving them the full printout. We're just giving them moderate risk, low need, high risk, high need, at least so they have something in their mind, because every judge's nightmare is to have their name in the paper because they let someone out that committed a heinous crime. So that's been a big a change in culture for us as well.
We have a jail health service that offers addiction treatment medication. So we have buprenorphine starts in the jail, which helps protect against overdose when the person's released, and also naloxone for opiate users when they leave. And if the person's on methadone, we have 7 methadone clinics throughout the city, but if the person's on methadone, they all courtesy dose at one methadone clinic so that that clinic can deliver the methadone to the jail.
The only other thing I'll add is with mental health first aid, we learned from the Department of Corrections that they were training their incarcerated populations. So I think maybe not losing sight in thinking about sustainability and impact as those who are being served. What additional skills could they also learn to affect their community? I also wanted to kind of highlight another initiative that we're internally in the process of really thinking through is with the leadership from our commissioner, thinking about the intersection of mental health and race, and losing sight of racial equity in some of these programs or initiatives, is potentially, not going to be able to facilitate the types of goals or improvements that we want to see. So part of that is really looking at agencies' operations and policies and practices using a social justice lens. In early spring of next year, we're going to be hosting a race and segregation and behavioral health in New York City to really highlight how do our city agencies address race, but also how does that intersect with mental health that is being provided across the city. And part of that is also the development of a Center for Health Equity center that really is at the forefront of really promoting and ensuring that we're integrating these different lenses in all of our work. And I think for Mental Health First Aid, it's certainly one of the areas that we're being very strategic and intentional in addressing, bringing this particular capacity building, skill development resource to communities that really could benefit. Because we know that if we're too far removed from it, the impact that we're intentionally trying to ensure here is really not going to be adopted by the community if we're the ones that are really just trying to push that forward.
Thank you. There was another question right back there, yes.
I have one. I'm Carrie. I work here in New York in the health hospital system as a medical social worker. And you all work in systems, big ones, as do I. And systems, by their nature, when they're large, are not hugely flexible. And you're talking about this amazing work, which is really changing systems and not making just one part, but the whole system more flexible, more responsive, more tailored. I'm curious to know, when you had to first start to have those conversations, when you first tried to push those systems to be a little bit different, what were some strategies that you found successful in those early shifts of culture?
Sure, I could address some of that. So I think in lifting such a large program off the ground, we have certainly learned a lot. And what at least we're hoping to see, and in terms of the benefits of engaging city agencies and really what we're calling our core implementation team. So these are champions of the work who have bought into the idea that if we don't address mental health, we're going to have that continuous loop. And so some strategies that we're considering, because our first 9 months of this work has really just been building this infrastructure. So now moving forward, some strategies that we're considering is really building a community of instructors to further engage those who have trained in mental health first aid, but also who are out in the community really discussing, these issues at that ground level. And so they have already bought into the idea, they see the value in the work, and they're really being champions. They want to spread the word. So the word of mouth for something like this is instrumental in making sure that it's sustained. Other things that we've considered are working with our interfaith or faith-based organizations. We do know that, and I think literature shows this, that a lot of these mental health issues could potentially surface in these areas among those who are seeking religious and spiritual answers maybe to some of the things that they're going through. And so engaging that community who has certainly brought to our attention the need for understanding mental health and how to address that. And then the third thing I'll kind of speak to is because you have this momentum and these conversations are starting, we have seen significant shift in how people are thinking about mental health and leveraging this to kind of now meet their own needs. So I've have at least 5 to 10 city agencies that have said, well, this is great. This is a great mechanism for us to start talking about mental health, reducing that stigma and getting those organizational changes to occur. But I also serve grandparents who are raising youth. And so how do I use this mechanism And I think that's how we're viewing it, at least within the Bureau, that mental health first aid is a mechanism to open a lot more doors, a lot more opportunities, so that we can bring and adapt these models to them. So that's a few strategies that we're looking forward to testing and developing.
One of the things I wanted to mention that I think is an impetus for change is the medical side of healthcare is experiencing payment reform at a faster rate than mental health or substance use. And they're finding, of course, as we've known all along, that their high risk is our patients, right? So that has prompted a number of efforts from the general health plans to improve the integration of substance use and mental health into the hospital, in particular the high-cost systems. So, for example, in San Francisco, and also residents are being trained in system reform too, medical students and residents. And sometimes they do projects as part of their training in the hospital. And so if you have hospitals that are training grounds for residents, sometimes you can have a subset of residents that are really interested in system change, and they can participate in that. In San Francisco, the residents set up what they called an naltrexone program, which was to offer every person who was inpatient and needed an alcohol detox, to offer them naltrexone before discharge because it helps control craving for alcohol. And they actually published a paper showing reduced readmission rates, which of course is one of the payment reform markers. We also, because there's readmission frequently related to heroin, the primary care clinics are co-prescribing naloxone with opiates, and a paper on that came out showing that it reduced emergency room use by prescription opiate pain reliever users. And we do buprenorphine starts in the hospital with follow-up at the office-based induction clinics. So there are a number of efforts using the medical model in primary care and hospital medicine.
For us, it's very, For us, it's very simple. Our cops are very smart people. And the vast majority, understand our mission, which is to serve. And they understood why doing this program with the training, the change in the culture was important for them in terms of their safety. They had to learn how to deal with these type of calls more efficiently and more safely, not only for the individual, but also for themselves. And the reality also is a litigation piece. That's where the SMART piece comes in. They understood that. And so, and then we were also very fortunate that we had a great relationship with our mental health, relationship with our mental health community. They were right there with us in terms of the training and the partnership and communicating and working with us on how we were going to evolve.
To respond to your question, the only thing I would add to that, when you talking about trying to get all the stakeholders involved from an agency, a system as large as what's represented here, we have what is called our Criminal Justice Council in Miami-Dade, where we meet quarterly, we meet regularly to discuss these type of issues. And the first step is about educating your stakeholders. You educate your stakeholders. At those meetings, we have representation from the courts, PDs, state attorneys, the commission, the mayor's office, the jails, and so forth. And what you'll find in those large systems where not everybody has an interest, where they feel like mental health may not be my issue, it may just be an issue for the jail, but it's really everybody's issue. It's the community's issue. So one of the ways we were able to get that buy-in is bringing up those discussions through our quarterly meetings and connecting the South Florida Behavioral Health Network, the residential treatment programs with the funding needed to make sure we address this issue from a holistic approach. So those were from some of the very first steps that had to take place.
Great. I think we have time for one more, like, super quick question. We have a okay.
Super quick.
Super quick question.
So I'm going to ask this to Dr. Martin and to Daniel. I just want to know, in both, and you talked about Suboxone treatment, that the jails or prison systems have Suboxone treatment in the jails and in the prison system. So if somebody comes in and was on Suboxone, but let's say they don't have the prescription, do you continue Suboxone through the program? Is that one of the changes that you made? Because I'm from Massachusetts, and the only thing that we have in place is that 1 month prior to you leaving was to get a Vivitrol shot. And so I would like to implement that if that is something that is actually happening, because we can't get it implementing. So if you did, it would be great to figure out your outcomes later, but I just want to know if that's the case.
Yes, we did. In September 2013, we started a project. Actually, the jail health director started a project to treat people who were uncomfortable because they were physically dependent on opiates and in withdrawal, and had a history of having an opiate use disorder on sublingual buprenorphine. And then when the person was released, they were given a referral to our central access point that includes a buprenorphine office-based induction center for stabilization and then placement in primary care. And the statistics showed that about 50% of the people made it to that OBIC, the office-based induction clinic, and most of those people were able to stabilize and get into primary care. Some were not. And at any rate, all of those people were protected against overdose after institutional abstinence, right? So, but the injection with extended naltrexone as a kind of goodbye shot from any institutional setting is also a practice that for people who really, really don't want to take any opiates at all would be a good protector as well.
So for Miami-Dade, I'm not a clinician, but I can say we're not there yet. We're currently not doing that. So.
Do you see that coming up in the future?
Maybe. Yeah. Well, if there's a benefit to it to our population, there's definitely something that's on the table. But as of right now, no.
Okay, so we have 1 minute per se. I just want to go down real quickly and for each person to just say one, call to action or what we should be doing. And a lot of it you elevated, but if there's one thing that you think is of great priority as it relates to changing the culture, and there are many ways that we have to go about changing the culture, but what's that one thing that you would elevate? And so 1 minute. We have not 1 minute per person, but kind of 1 minute total. So if we could go through that, that would be great. So we could walk away with some action.
So if we're going to start at this end, I guess my takeaway that I would encourage you to walk away from this meeting with is to invest in your residential treatment. I know the Department of Justice is in several discussions with a number of different jails across the country with regards to treatment in jails and construction of new mental health treatment centers. But if we don't address this issue from a community level, we'll never be able to keep up with the rate of incarceration for our mentally health. So I would just encourage, we have a model. It may not be the best model, but we can definitely share what we're doing in Miami-Dade to address this from a residential standpoint.
My take home is going to be reform involuntary hospitalization laws. We are basing our laws on the dangerousness criteria, which is based on the 1700s.
Again, I would like to say that I think it's imperative, and this is not just from the Houston Police Department, because we're very fortunate to have our mental health authority with Dr. Schnee, but with the other law enforcement agencies across the nation, it is imperative that the mental health authorities speak to law enforcement about that population that's using police officers, sadly, for mental health care. They need to get the help that they need, and mental health authority has got to engage them.
Funding for you guys to be able to help us to do what we need to do and continue that collaboration. Because I think it's going to grow. I mean, I could see something, a similar program with domestic violence. But again, it takes money and it takes people and a vision. Thank you.
I would say address people who use drugs and alcohol's health issues, regardless of whether they want treatment or not.
So to change the culture, our call of action is to sign up for mental health first aid or incorporate it into your new hire protocol. We're really tackling the barrier of stigma when it comes to mental health.
Great, and thanks to the panel. And I just want to add also is that at the end of the day, and I don't know if end of the day is the right word, but a lot of this is we have to really begin to also affirm people's humanity. A lot about changing culture. Yes, we have to change systems, and we have to think about big systems and how do we do that. But there is the heart's piece to it. And I think, to me, the reality of everything that's happening right now in our country, that it can't just be about system change. And how do we get to people's hearts is very much at the core of how we change culture and transform systems ultimately. So I want always to kind of, for that to keep in the back of, or forefront actually, of people's minds. Hearing the stories of people's experience helps us better understand actually how to transform systems and not be in our silos of operation or our guarded positions in which we are not very much connected to the people who are actually experiencing the injustice that is happening in this country. So with that, I want to thank the panel and really the audience as well for your patience as we, had to thrive, during this session. I think everyone did an exceptional job, so thank you.